All right, so I am at Nationwide Children's Hospital, for those of you who don't know, which is in cloudy Columbus, Ohio. We, I love it here, but we actually have more cloudy days than Seattle, apparently, in a newspaper article that came out recently. I didn't realize that. But it's actually sunny today, I think, at least it was when I got to work. So um, this is our mission statement. We wanted to be clear in why we were integrated within psychology. We have a massive behavioral health system here. We have we probably have over 200 therapists, psychologists, LMFTs within our pediatric system. We're in over 20 of the schools. So we have this massive behavioral health system, and we wanted to be clear about why are we expanding into primary care. Also, as we were developing the program, it was helpful to us to have a mission. So, everybody has ideas across the whole organization about how it should or could look, and having a clear mission helped us navigate some of those things. So saying like, well, that's a really good idea, but I'm not sure that meets this part of our mission or that part of our mission, or help me understand how, you know, doing more co-located therapy is going to help, our mission, if our mission is to increase access across the board, because we already know there's a lot of access to that already. I think what we need to do is a more integrated model. We have tons of specialty services available throughout the city already through the schools and close to home centers that are located in the neighborhoods where outpatient psychologists work. So it kind of helped us really develop our model into what it is today by having a clear mission. And that's just increasing access to culturally competent behavioral health. That providers and families both find satisfactory. We're highly connected to the communities that we serve. So one of the unique things about our model is pre-COVID, we were doing over 30, as a group, we were doing over 30 community events a year. So for example, Linden is a really tough neighborhood. It's a food desert. There's not a lot of grocery stores. There's a lot of need in that population. It's kind of a high crime neighborhood. And there's all these community organizing events, like they do a jazz festival to help raise money. They do some awareness activities, some clean up the neighborhood activities. And so we do over 30 activities in the neighborhoods that we're associated with throughout the year. And that's not just like volunteering at a soup kitchen in the community. We only count them if we take a lead role or we take a really active role within the planning, organization, and implementation of that. So we're really try to be connected to the communities we serve. Columbus is a super diverse city. We have lots of refugee immigrant population as well. And so being part of those community activities help reduce stigma when we show up in the office visit and they've seen us in the community. It really helps increase trust and break down some of that stigma. And we learn a lot about how to present our own services and the concerns that exist in the community as well, to help address those things. So that's kind of a big part of our model. Obviously, we want to make sure our medical teams are learning from us and becoming more comfortable in treating mental health conditions or behavioral health needs. And we also, I said we had a huge behavioral health system, which is true, but they're really overwhelmed just like everybody else. It seems like the more you build, the more needs you still have. And so we still have wait lists that are 6 months, 12 months, 14 months to get into some of our specific programming. So we really wanted to reduce some of the pressure on them by treating some of those kids within their medical home. This is kind of the step level of care that we use. So it's at first at that bottom layer, it's, I'm a school psychologist by training. I couldn't develop a model without having a triangle associated with it. If anybody's a school psychologist, they can appreciate that. At that first level is this kind of primary care level with indirect support. So we're on a lot of our work groups. So like the QI work group, how do we manage depression as a primary care network? We're on that work group to work on our workflows. We do curbside consultations and universal screening. We do a lot of early childhood prevention visits when we're not seeing kind of a billable visit. We're going into 2 months, 4 months, 6 months, 12 months, 24-month visits and doing some enhanced anticipatory guidance. We also do joint appointments, both warm handoffs, for that 3-year-old that comes in with picky eating, or our teenager who just came in with, not sleeping for days at a time. We also do joint follow-ups. So that might be a kid who's coming in for med checks, like an SSRI check or an ADHD check, who aren't otherwise engaged in therapy. We'll do some joint visits where we do behavioral consultation or CBT or those kind of things in conjunction with their medical visit, kind of in a planned follow-up. Then we have psychologists in the clinic who do like 3 to 5 modular treatment sessions on our own schedule. About 75% of our contacts pre-COVID were on the physician schedule, and about 30 to 25% were on our own schedule. We also have started hiring co-located therapists to help us deal with the volume, and they kind of have the reverse. So 70% of their patient contacts are on their own schedule, and then they jump in and help with integrated work about 30% of the time. Maybe because one of the patients they're following is here, or we're just getting slammed and overwhelmed, they'll jump in and help us on the integrated side too. So those are usually master's level LISW or LPC or LMFT folks who are helping us on the kind of co-located side. And then, of course, when that isn't enough, we send to specialty behavioral health. I'm running a little bit long, so I'm going to skip over this because this is just another way to kind of show. We really liked, though, this figure to explain to leadership and to primary care leadership, behavioral health leadership, hospital administration, about how integrated primary care is different than just regular specialty behavioral health. If you look on here, we do many more activities that help primary care take better care of families and that help behavioral health as a system take care of families than we do just direct intervention with families. And so we really kind of grease the wheels of the system. And I think this figure helped us kind of communicate that to the leadership and understand how what we do is a little bit different. Like I said, we're highly integrated. About 70% of our visits are on the medical provider schedule. We see whatever walks in the door, whether it's helping a mom stop breastfeeding or, get ready for college, a teenager get ready for college, or ADHD, whatever it is. And we try to see about 7 to 10% of the visits of all the kids who walk in the door, regardless of the reason why they're here or their age. We have a really broad team. We're really fortunate. We're kind of resource rich here in a lot of ways, which sometimes it's hard to keep us all organized because there's, 5 people who want in the room to see the family, and it can be overwhelming for them, and they leave with a really broad plan. So, having a lot of resources isn't always just a blessing. There's a lot of work you have to do to keep us all organized. But we have medical trainees, social work trainees, pharmacy trainees, of course, our clinical assistants, our social workers. We have a medical legal partnership. We used to have WIC in clinic, which is women, infants, and children, to help with formula and food needs and different things. Like I said, clinical pharmacists, us integrated psychologists, both the psychologist and the co-located therapist as well. So we have a pretty broad primary care team here. We have 7 psychologists spread across 7 clinics. We're in clinic 4 to 5 days a week. We have an intern that's here half a day, twice a month. Normally we have a fellow. We actually took 2 fellows this year. So we're gonna have 2 full-time primary care fellows for next year. And like I had mentioned, we have co-located therapists in our downtown, Sharon Woods, East London, West Side locations. I'm in the downtown location. This is just kind of volume over time. We're steadily seeing more and more kids. This is number of visits per year. This is a slide that I think is really cool. So compared to our non-integrated clinics, kids are 134% more likely to see a behavioral health provider in the clinics that are integrated. I think the thing that's really remarkable about this is, this kind of seems like a I'll say no duh, a no duh hypothesis, right? You put a provider in a clinic and they're going to see more kids. But I think the remarkable thing is this is during our initial pilot when we only put 4 psychologists in the clinic. During the same time frame, we've hired 70 to 80 different behavioral health providers within our specialty care network, which made a 0.5% difference. So hiring 80 people in the specialty side of our system made 0.5% of a difference, which is not statistically significant in access to our non-integrated clinics, but putting 4 people into the primary care center doubled the amount of access to our primary care network patients. And so kind of at first look, this graph looks like, well, of course, but I think within that context, if you want to see like percent of kids seen per FTE, putting them in clinic is kind of a big deal. 93% of the kids that we see the day they come in to the primary care doc. And so there's 0 wait time, but for the 7% of kids roughly that we don't see because we're doing a presentation or we're sick or we're out of clinic or whatever it happens to be, we see about them in about 15 days on average versus 67, which is the average wait list for specialty behavioral health. Our hospital has a metric of wanting them to be seen within 30 days. About 91% of the kids we see are within 30 days. And only about 36% of those with specialty care. What's important with that specialty care number is that includes our our crisis team. So we have a whole crisis team whose job is to bridge kids who are in crisis until they can get seen with outpatient providers. Oftentimes we're getting kids in faster than the crisis. So, we'll see them for a checkup here in primary care while they're on the wait to get scheduled with our crisis team. Our physicians are super satisfied so far with our model. They feel like they're more confident, they're learning skills, they're getting their questions answered, they're more efficient, things are more coordinated. I think this is a really cool slide too, is that we actually see a lot more of the birth to 2 range. So we see significantly younger population compared to our specialty behavioral health colleagues. That 0 to 2 range is much higher for us. And we know that getting to kids early is really important when it comes to mental health treatment. And then this is just kind of like where we're at moving forward. Like how to measure clinical outcomes when we treat everything under the sun. It's hard. Like there's a lot of research on collaborative care models because they focused on 2 or 3 conditions and they focus on the whole population, and they have a specific set of population health practices that they all use that's easily measurable for fidelity. But when you're treating, I think one time we tried to code all of the things that we treat, all the diagnoses we treat, and I think we had like 15 to 20 codes at one point. Like, how do you have an outcome measure that's both equally going to measure progress of a mom stopping breastfeeding as well as like a kid with OCD and a kid with ADHD? Like, what measure includes all of that, and how can we think through clinical outcomes a little bit better? How do we bill for anticipatory guidance? We currently just do that for love of the game. We're not getting reimbursed for that. That doesn't add to our productivity. We have a large amount of non-billable services that we're doing. And then the last thing is just how do we, it's hard to come up with an accurate system that determines, okay, you can just stay on the primary care schedule. You are probably going to fit better in that 3 to 5 appointments with me. Oh, wait, no, you'd probably better with that up to 12 with the co-located therapist. It's really hard to predict within our SEPT model kind of what they need. And the initial thought of like, well, we'll just put them through all the steps and graduate them onto the next step isn't super easy for families because they're meeting these new people all the time. So, they meet me on the provider schedule, then they're doing 3 to 5 sessions with me, then they're going up to the co-located therapist, changing providers there. If they don't make progress with that person, then they're going to the specialist, which is another change in providers. And that's really hard on families over time to constantly be starting over with new people. So these are kind of some of the things that we're really struggling with and thinking through in our model.
That was great, Cody. Thanks for overviewing that. And I think those are great slides to present to leadership wherever people are, just the kind of the metrics that you're pulling to justify that service. And I was wondering if you could, so do you have a one co-located therapist and then one like BHC psychologist in each practice then? And could you talk a little bit more about how how many is that per pediatrician or physician that you have?
Yeah, so we currently have 2 co-located therapists that are currently on. We're having a little bit of a turnover with our co-located therapists right now. So we have 2 currently, and they're split between. So they spend 4 days a week in our busiest clinics, and then they spend 1 day a week in some of those moderate clinics that could just use a little bit of help. And so we haven't necessarily had we haven't had a rule as far as like BHC to panel ratio or BHC to PCP ratio necessarily, but it does work out that they spend more time in the busier clinics. We based it more off of provider productivity than overall volume. We have some bigger volume clinics that for different reasons aren't keeping us as busy. And so we want to kind of problem solve that before we add a co-located therapist into a clinic where the BHC already isn't making productivity. So we kind of identified those BHCs that were over productivity and were feeling like they were drowning and not getting to everybody. And we kind of started with them first. And while we problem solve why some of those other busier clinics aren't quite at productivity yet, before we throw another person to vacuum productivity away from them. The other thing about our network is that we don't have great continuity between clinic. not just within provider, but even within clinic. So it's not uncommon for one of our kids to be seen in Sharon Woods clinic and then 3 months later come to my clinic because the Sharon Woods clinic didn't have something as soon as what they wanted, or they had paperwork that needed filled out. And we haven't created rules within our system that you can only be seen within one clinic, let alone one provider as well. So that kind of limits some of our model and some of our work too.
From a training onboarding perspective, are you training the co-located folks to be BHCs as well?
It didn't start that way, but it's kind of working that way. So we kind of got them set up to be more manualized in their treatments and trying to be more systematic about the work that they do. But we've had a couple, like the one that works in my clinic, Alyssa Lynn Combs, she's just phenomenal. Like I'd put her skills up with any psychologist I've ever met before. And so she's actually, our psychologist left for maternity leave, and then with COVID and everything decided to not come back. So we had unfilled BHC time the second half of the week, and my time's bought out for that. So we were kind of uncovered, but we actually just turned her into a BHC those days, and she's absolutely killing it. So there is this thought now that can we use this to identify those co-located therapists who seem to have what it takes to do the integrated work, and then put them into some of these other clinics as we go on to expand. So it kind of naturally developed that way, that oftentimes they're coming in pretty green or don't have a lot of experience. And so that integrated work's overwhelming. But as they get the training and get the experience, we're finding that they're able to kind of step into these more integrated roles over time.
Thanks.
Yep. Good questions. But I missed it. Oh, paper. Working on it. Thank you.
I was saying specifically with the kind of lack of impact of the huge expansion of especially behavioral health, with like the much better bang for the buck impact of the integrated care.
Yeah, for sure. I think we're writing that up right now. We hit a little bit of a wrinkle, but I think we're good to move forward. We were trying to put too many outcomes in one paper. It's the feedback we got, so we kept it to just an outcomes paper. I don't know if you guys saw the Walter paper that came out in 2019 in pediatrics, but they measured like literally everything under the sun, and we wanted to publish in pediatrics, so we put like every outcome that we had in one paper, and they're like, yeah, this is too much, just focus on access. And we're like, okay. So hopefully we're going to get that written up soon. And yes, I'm happy to share the slides for sure. I have an expanded deck too. I'll throw some of the other slides in that of some of our other evaluation metrics that we've used too.
I think also the having the hybrid role for the collocated and the VHC might impact your turnover, because at least in our network, the practices in the PPOC that have more collocated models, staff are burning out during COVID. Because some of them were doing all the work remotely and so on, versus the more integrated clinicians that have also collocated roles, but mixed with availability for one handoffs that are back at the practices, because immediately when it could happen, the teams wanted them back because they missed this more integrated piece. So I think that's important. But I have a question for you for our presentation for the conference. How did you recruit the culturally competent clinicians?
Yeah, we just try to make it really clear in everything that we do. So like in our recruitment stuff, we talk about our community outreach and the fact that we're heavily involved in, for example, like the CRIS refugee organization. And we emphasize right off the bat that it's kind of an expected part of the role. And I think people have started thinking about us within that role. So we've had some people apply recently who's like, oh, you're interested in cultural stuff, you should apply to NCH kind of things. And so we're hoping to just kind of develop a little bit of a reputation that we try to do that. And we've been really fortunate to recruit. We take a really intentional approach to recruiting and diversity on our team. So we have a person who speaks Spanish, and she's starting a seminar for people who feel like they can kind of speak Spanish, but they want to brush up. So she started a seminar to help with the professional Spanish speaking skills. It's kind of not quite supervision, but it's kind of like a group where they kind of work on developing some of those skills. And like I said, we've been intentional about recruiting when it comes to diversity and where we recruit from and how we word some of the messaging and those kind of things.